Friends, today we will be talking on a new topic called MINOCA, which stands for myocardial infarction with non-obstructive coronary artery. There is no obstruction in coronary artery, despite that myocardial infarction occurs. So how does MI occurs if coronary artery is normal? Normal or nearly normal. So the definition of is that if the stenosis is 50% or less, it is called nearly normal coronary artery. So let me write the term here, MINOCA. MI with non-obstructive coronary artery. So this is per se not a disease, but this is, you can call this as a syndrome. Why I am calling it as a syndrome? Because there are various causes of MINOCA, and you have to identify what is causing that MINOCA, because the prognosis of the patient and your treatment modalities will be directed towards cause rather than just focusing on only on MI. Okay, so this is the umbrella terminology, and under this umbrella what falls? Another one is atherosclerotic process, other is embolism, dissection of the coronary artery, that is called spontaneous coronary artery dissections, epicardial coronary artery spasm, microvascular dysfunction of the coronary artery, that is also called cardiac syndrome X, or angina pectoris with normal coronary artery. Other is viral myocarditis, which accounts for 1/3 of the causes of MINOCA, Taktsubo cardiomyopathy, so let's start one by one. So I like to lump this etiology under two classes. This is not based on any guideline, but why I would like to lump this into two classes, because it will be better understanding. One is the pathology in the epicardial artery and another in the microvasculature. In the epicardial artery, let's suppose if there is spasm, and analogous to that there is coronary microvascular dysfunction. Okay, so a spasm of epicardial artery, and this is a spasm in the microvasculature, that is called cardiac syndrome X, or angina pectoris with normal coronary artery. In the epicardial artery there can be dissections of the coronary artery, that is called spontaneous coronary artery dissection. Okay, and other one of the causes atherosclerotic plaque rupture, erosions or calcific deposits. Those are epicardial causes, and microvascular causes are microvascular dysfunction. And I already told you about Taktsubo cardiomyopathy while drawing this umbrella, viral myocarditis. So let me write this. So epicardial. Under epicardial, one is atherosclerotic plaque rupture, erosion or calcific deposit. Second is a spasm of the coronary artery. And third is a spontaneous coronary artery dissection. And under microvasculature category, what I told you, analogous to a spasm is microvascular dysfunction of the coronary artery, that is also called cardiac syndrome X, or angina pectoris with normal coronary arteries, Other viral microvasculature cause are embolism. When there is embolism in the coronary artery. Another cause is Taktsubo cardiomyopathy. And another cause is viral myocarditis. And you know guys, viral myocarditis accounts for 1/3 of the causes of the MINOCA. So this is one of the important causes. So while talking about etiologies of this MINOCA, let me give you one example. Let's suppose a patient has femoral fracture and he bled significantly, and that led to decreased blood in the circulation, leading to decreased perfusion and had MI. So, does this falls under MINOCA? No. Another instance, let us suppose a patient had COVID, ARDS from COVID, and his oxygen saturation was 40%, 50% despite maintaining oxygen delivery devices. So, patient went into MI. So, does that falls under MINOCA? No. So, you have to exclude those. And whatever etiologies I have discussed, these falls under MINOCA. So at this point of time, I am remembering about one case. That case was about 35-year-old male who presented to emergency department with complaint of chest pain, and he had ST elevation, myocardial infarction, with troponin was positive, and on angiography there was about 40 to 50% stenosis of the coronary artery. Only 40 to 50% stenosis, but he had ST elevation, myocardial infarction. So in that case, when we did intravascular ultrasonography, it was found that there was plaque rupture. So that is the importance of these intravascular imaging modalities, intracoronary imaging modalities like OCT, intravascular ultrasonography, cardiac MRI. And another patient, about him, what I can tell you that he had fairly normal coronary arteries on angiography, no obstruction was there, and he had presented with NST elevation, myocardial infarction, non-ST elevation with tube inversions in the inferior leads. And on intravascular ultrasonography, there was erosion of the plaque. That is the importance of this intracoronary imaging modality, because with angiography you cannot interrogate the lumen of the coronary artery. Okay, so that I will be discussing on the investigation part, but why I told you at this point, because I just remembered those cases. So let's discuss the etiology one by one. So we discussed, we told you about atherosclerotic plaque rupture, erosion, or calcific deposit can be one cause. Another cause is a spasm of the epicardial coronary artery. Epicardial coronary artery. Another cause is a spontaneous coronary artery dissection. So this is the coronary artery, and let's suppose this is the media, and this is the intima, endothelium lining, and this is the adventitia. So when blood starts seeping inside this, so when blood accumulates, what happens? The blood expands, and this encroaches the lumen, and thus narrowing the lumen further and further as the blood goes seeping inside it. Okay, so that is called coronary artery dissection. And for this, do you do PCI? Unless there is hemodynamic instability, you don't go for PCI, because this dissection tend to heal spontaneously. So this is also one of the cause of the MINOCA. And now let's coming to our microvascular causes. So one, I told you that microvascular dysfunction of coronary artery, that is called cardiac syndrome X or angina pectoris with normal coronary artery. So here What is the dysfunction? If you give intracoronary acetylcholine or ergonovin, you can observe a spasm of the coronary artery. That is the dysfunction. And here, even intravascular imaging modalities, you cannot see anything. When you give ergonovin challenge or intracoronary acetylcholine, and then only you can diagnose this. But at this point, I would like to tell you that even in USA, many institutes does not prefer this intracoronary acetylcholine challenge test, because even normal coronary artery undergoes a spasm with intracoronary acetylcholine. So take this with a grain of salt. So this is about microvascular dysfunction of the coronary artery. Another is viral myocarditis. I already told you it accounts for 1/3 of the causes of the MINOCA. Another is Taktsubo cardiomyopathy. You may be already knowing about this. This is ballooning of left ventricle, apical ballooning. When there is ballooning 1/3 to 2/3 of akinesia, or if you see dyskinesia on echocardiography, you can tell that this is Taktsubo cardiomyopathy. And another cause is coronary artery embolism. So emboli inside coronary artery. So which category of patients have more predisposition to coronary artery embolism? So obviously patients with prosthetic heart valves, who has atrial fibrillation, who has DCM with left ventricular thrombus, infective endocarditis, rheumatic heart disease, having mitral stenosis, those category of patients have high risk of this coronary artery embolism. And also you may be knowing about paradoxical embolism. When there is intracardiac septal defect, what happens? Emboli goes inside the systemic circulation. So this emboli can lodge in the epicardial artery as well, but generally when a smaller emboli goes towards the distal circulation and obstruct the microvasculature. That's why I have discussed this in microvasculature section. So these were the causes of the MINOCA. And diagnosis, obviously patient presents with the complaint of chest pain, like just similar to EMI. And you do ECG, cardiac enzymes, blood investigations, those are just similar to EMI, but you have to focus what is causing this MINOCA. So for that you have to also do investigation. Like let's suppose I already told you about viral myocarditis if you suspect, or if you suspect Taktsubo cardiomyopathy, then you can do cardiac MRI with contrast or without contrast, okay? And I already told about IVUS, which is intravascular ultrasonography, and OCT. These are intracoronary imaging modality to interrogate coronary lumen. Intracoronary imaging modality. For example, for spontaneous coronary artery dissections, or for plaque rupture erosions, it will better identify. And even if you don't get any abnormality in IVUS OCT, then you can go for acetylcholine challenge test. Acetylcholine challenge test. You inject intracoronary acetylcholine and check for a spasm. So these were diagnostic modalities, investigations that we should do. And regarding treatment, so obviously you have to treat MI, because this is MI but there is no obstruction. So treat MI with dual antiplatelet for at least 1 year, and then change to single antiplatelet, statin, high dose statin. Another is beta blocker, ACE inhibitors. So this part you have to manage, and also you have to manage there is no obstruction. So why this MI has occurred? So treat underlying etiology. underlying etiology of MINOCA. For example, there is vasospasm. I told you that you have to give vasodilators, calcium channel blockers, nitrates to prevent further episodes of MINOCA. Okay. So I hope you understood this. If you don't understood any of the terminology, you can comment down and I will reply. Thank you.